warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Dear students of fourth year MBBS, today we will discuss cornea, its basics and clinical evaluation of the corneal diseases. The learning objectives of this lecture are that at the end of the lecture we want to know clinical anatomy of the cornea, general symptoms and signs of keratitis, what is the classification of keratitis, and general principles of management of corneal diseases. The cornea, an interior transparent layer of eye, it makes 1/6 of the interior layer of the eyeball. In this picture, between the layers, you can appreciate the eyeball, and the colored portion is the cornea. And upper 2 millimeter of the cornea is normally covered by the lids when individual is seeing straight ahead, means in primary position. So now we will discuss the clinical anatomy of the cornea. The normal average corneal diameter is 11.5 millimeter vertically and 12 millimeter horizontally. But cornea posteriorly is the 12 millimeter horizontal and vertical dimensions. And corneal thickness in the center is about 5 millimeter, that is 500 micron meter. And at the periphery it is 0.65 to 1 millimeter. Usually the average is about 0.69 millimeter at the limbus. So this importance of this corneal thickness is in certain diseases like keratoconus, where the thickness, central thickness is decreased and cornea become conical. In primary open angle glaucoma, cornea become thickened, particularly the central cornea having thickness more than 0.6 or 0.65 millimeter is depicting of primary open angle glaucoma. And in refractive surgery, we measure the corneal thickness, and according to the thickness, we suggest the different types of refractive surgery, and we calculate how much cornea we can ablate. And the refractive index of cornea is 1.37 at an average, and the refractive power of the cornea is 43 diopter. So this cornea is a component of converging system of the eye, and total power of the converging system of the eye is about 60 diopter. And out of these 60, a major portion is contributed by the cornea, that is about 43 diopter. So cornea has 5 layers, starting from the outer to inner is the epithelium, then comes the Bowman's membrane layer, then comes the stroma, Descemet's membrane, and the endothelium innermost layer. The epithelium is a stratified squamous non-keratinized epithelium. Its thickness is about 50 micron meter. And the basal cells are the columnar cells, and they are about 50 micron meter cells. And the stem cells are located principally superior and inferior limbus, and they differentiate into epithelial cells. So if the stem cells are damaged, chronic epithelial defects occurs. So epithelium is a self-regenerating structure, and it can regenerate. If we ablate the healthy epithelium, it can regenerate 24 to 48 hours. And after a lifespan of few days, the superficial cells shed into tears. Right side of the picture shows the 5 layers of the cornea, and the outermost layer is the epithelium, which is showing as an enlarged portion. The basal layer consists of columnar epithelial cells which are about 15 micron meter in length, and they are attached with the basement membrane with the hemidesmosomes and with each other with the desmosomes. And the next 2 to 3 layers are the wing cells, and then comes 2 layers surface cells, and the outermost cells have the microvilli which protruded into the tears, and it holds the mucin and tears. And the second layer of the cornea consists of called Bowman's membrane. It is about 8 to 14 micron meter thick, and it acts as a basement membrane of the epithelium. It is a condensed collagen fibrils and form a acellular layer of the stroma, and it cannot regenerate after trauma. And the third layer is called the stroma or the substantia propria. It forms about 90% of the corneal thickness and consists of the collagen fibrils. And these collagen fibrils runs from limbus to limbus, and they are uniform in size, are regularly arranged, and they are arranged in layers. If one layer runs horizontally, the other layer runs vertically. And the fourth layer is the Descemet's membrane. It is about 10 to 12 micron meter thick, and it acts as basement membrane of endothelium. This layer is unable to regenerate, and its peripheral termination is called Shelby's line, which is visible by the gonioscopy when you visualize the angle of the anterior chamber. And this Descemet's membrane offer highest resistance whenever there is a deep ulcer. This membrane offer a highest resistance to the perforation. In this picture, you can appreciate the last layer, that is the endothelium. It consists of single layer of hexagonal cells, and at birth they are 4,000 cells per millimeter square. But in any adult, its density is about 2,500 cells per millimeter square. And they throughout decreases in number, and they cannot regenerate. The neighboring cells expands and fills the gap. Once the number is below 500 cells per millimeter square, corneal edema is bound to occur. Now come to the nerve supply of the cornea. It is supplied by the first division of the trigeminal nerve, that is the ophthalmic nerve, and its branches, long ciliary nerves, divide and forms subepithelial and stromal plexus. Per capita nerve endings and epithelial plexus are highest in the cornea. So cornea is a very, very sensitive portion. And as far as blood supply of the cornea is concerned, it is an avascular structure, but only about 1 millimeter of the peripheral cornea is supplied by the perilimbal plexus. Corneal nutrition is gained from the aqueous humor posteriorly, and tears interiorly supply the nutrition to the cornea, as it is a avascular structure. So due to avascularity of the cornea transplant is highly successful as compared to the other organs. Now, how the corneal transparency is maintained? We can divide into two factors, anatomical factors and physiological factors. The anatomical factors are uniformity and regularity in the arrangement of epithelial cells. Having hemidesmosomes and desmosomes compactly arranged, and water cannot pass through these compact epithelium or healthy epithelium. And the substantia propria, the collagen fibrils or the corneal lamellae having uniform size and arrangement. And here in this picture, you can appreciate this is a cross-sectional view of fibrils arranged in lattice. Here you can appreciate that each lamellae or fibril running limbus to limbus is equally spaced, and this space is less than a wavelength, so diffraction of the light does not occur. If due to edema this spacing is disturbed, then due to internal reflection of the light, cornea appear opaque. And the compact endothelial layer, the aqueous cannot pass through this compact layer of endothelial cells into the substantia propria. And of course, the absence of blood vessels. No blood vessels are present in the cornea. It's an avascular structure. And the physiological factors are the epithelial pump and the endothelial pump. The both pumps are energy consuming pumps. They actively pump out the sodium and potassium out of the cornea into the tears by the epithelium and into the aqueous by the endothelial pump. And along with the sodium, potassium, water is drained out, so they maintain a relatively dehydrated cornea. Endothelial pump is stronger than the epithelium pump. And if endothelial pump fails due to any reason, due to less number of endothelium or due to diseased endothelium or due to any other disease, then opacity or edema is bound to occur. Now come to the classification of the keratitis. Keratitis means inflammation of the cornea. It may be due to microbial causes or it may be non-microbial. The infections due to microbial causes are the bacteria, fungi, virals, and acanthamoeba. It is a protozoal keratitis. Bacteria further divided the different bacteria as mentioned: Neisseria gonorrhea, Neisseria meningitidis, Clostridium diphtheria, and Haemophilus influenza. These are the bacteria which can penetrate the healthy intact corneal epithelium. But other bacteria, Pseudomonas aeruginosa, Staphylococcus aureus, Streptococcus pyogenes, and Streptococcus pneumoniae cannot penetrate the healthy intact corneal epithelium. This Staphylococcus or aeruginosa causes a strong severe type of corneal ulcers, particularly in the hospital infections. It flourishes in the vegetation, soil, and moist conditions of the hospital. And it is the commensal of normally present in the GIT tract. And Staphylococcus aureus is a gram-positive bacteria and present normally in nares, skin, and conjunctiva. Streptococcus pyogenes is a gram-positive bacteria and normally present in throat and vagina. And Streptococcus pneumoniae, a gram-positive bacteria, normal commensal of the upper respiratory tract. The fungal keratitis, mostly the two types of fungi, the Candida and Aspergillus, causes the fungal keratitis. And the viral keratitis, usually due to herpes simplex, herpes zoster, and adenovirals are the culprit causing the keratitis. Now come to the non-microbial causes. So non-microbial causes of the inflammation of the cornea, it may be the hypersensitivity reaction. Hypersensitivity type 1 reaction causes catarrhal marginal ulcer and type 4 reaction causes flectanular ulcer. It may be autoimmune as in Moran's ulcer. It may be neuroparalytic in case of seventh nerve palsy, and it may be neurotrophic in case of ophthalmic nerve lesions, as the ophthalmic nerve supplies the cornea. It may be due to exposure keratopathy in cases of proptosis due to any cause, or the nutritional deficiency, usually of vitamin A and protein deficiency, or it may be due to tear film abnormality causing keratoconjunctivitis sicca, or it may be due to chemical burns, usually due to acid and alkali, or the keratitis may be due to eyelid abnormalities, trichiasis called misdirectional eyelashes, and the entropion, where whole of the lid margin is turned inward. So this misdirectional eyelashes are where the whole of the lid margin is turned inward, the eyelashes rubs against the cornea causing the keratitis and ultimately erosions and ulcers. Few age-related degenerations as arcus senilis, Vogt limbal girdle, cornea guttata, lipid keratopathy, band keratopathy, and spheroidal degenerations, and corneal dystrophy. We will discuss it in next lectures. Now, what are the clinical features of corneal diseases? Come to the general symptoms involving general symptoms in corneal diseases. The patient may complain of having blurred vision, eye may be red, foreign body sensation, lacrimation means eye is teary, photophobia where the patient complains of having a problem with the light, and patient may complain of having mild to severe pain and discharge which is usually scanty. And signs which you see on examination in corneal diseases are the circumcorneal congestion, eyes red around the limbus due to dilatation of the circumcorneal vessels, usually the ciliary arteries, ciliary vessels. So there may be punctate epithelial keratitis. It means the epithelium is intact, but swelling of the epithelium, opalescent swollen epithelial cells. Punctate epithelial erosions may be there. Subepithelial infiltrates due to invasion of the leukocytes and debris into the subepithelial or substantia propria. Corneal filaments, these are the mucostrands enveloped by the epithelial cells. Epithelial edema, then corneal ulceration, and long-standing corneal ulceration and irritation may lead to corneal vascularization that may be superficial or deep. And folds in Descemet's membrane may be present. Similarly, breaks in Descemet membrane and outpoaching of the Descemet's membrane, that is called descemetocele. In this picture, you can appreciate that when we examine the cornea, we draw the figures like that, and by the color coded, we can appreciate that the pigments are drawn brown, keratic precipitates as yellow, old scars as black, then hypopion as yellow, the wavy circles as epithelial edema, and the wavy lines, blue wavy lines as stromal edema. In this picture, you can appreciate on left hand upper picture, that is a punctate epithelial erosions. These erosions, fine erosions in the epithelium stained with the fluorescein. And in picture B, upper right hand side, punctate epithelial keratitis, where you can appreciate the opalescent swollen epithelial cells looking whitish. And in picture C, left hand lower picture, you can appreciate the unstained filaments. They are mucostrands lined by the epithelium. And on right hand picture, you can appreciate the epithelial edema. In this picture, on upper left picture, you can see the superficial vascularization. These are the vascularization which starts peripheral to the limbus and passes on the cornea. And the deep vascularization, you cannot find this start on the sclera or conjunctiva, just starting from the limbus, looks like to be starting from the limbus and passes into the substantia propria. In left lower picture, you can find the deep infiltrates. And deep infiltrates are the penetration of the leukocytes and debris into the substantia propria, and overlying epithelium is intact. And deep corneal ulcer, where the overlying epithelium is denuded and the substantia propria is involved along with corneal ulcer, there you can see the infiltrates in the bed of the corneal ulcer. And upper left picture, you can find a healed corneal ulcer with lipid deposition and vascularization. And upper right picture, you can appreciate the folds and Descemet's membrane. These folds and Descemet's membranes are present in cases of ocular hypotony or surgical trauma. In lower left hand picture, you can appreciate breaks in Descemet's membrane. And these wavy lines are healed breaks in the Descemet membrane. They are called hapstri. And these breaks are usually due to enlargement of the cornea. In left hand picture, you can appreciate that due to different methods of examination on slit lamp, you can appreciate certain lesions more properly. By direct illumination, you can find the general outline of the cornea, general luster and appearance. For you, this general direct illumination is important. You can see the cornea with the help of torchlight and find whether the cornea is transparent, shining or otherwise. But with the help of slit lamp, we can very accurately diagnose where lies the lesion. And with the help of scleral scatter, where the light travels into the substantia propria or into the cornea due to the internal reflection, we can appreciate the epithelial and subepithelial edema. And in case of retroillumination, where the light reflects from the iris or with the dilated pupil from the retina and passes from backward to interiorly, we can appreciate the endothelial and epithelial lesions very accurately. On right hand pictures, you can see in upper right pictures punctate epithelial erosions stained with fluorescein. And lower pictures, you can appreciate punctate epithelial keratitis, white opacities, not stained with the fluorescein. In left upper picture, you can appreciate the corneal epithelial edema when it becomes severe, as you can see on the right upper picture. Here, there you can find the epithelial vesicles and small bullae. And in left lower picture, you can appreciate the penis formation. Penis formation is the non-specific vascularization, subepithelial vascularization. These vessels travel underneath the epithelium and along with degeneration of the epithelium and superficial substantia propria. In the right hand picture, you can appreciate the anterior stromal infiltrates just near to the limbus at 3 or 9 o'clock position. In this upper left picture, you can appreciate the stromal corneal edema, generalized haze in the substantia propria. And on upper right picture, stromal vascularization. The vessels travels into the cornea underneath the epithelium into the substantia propria. In the left hand lower picture, you can appreciate the breaks and Descemet's membrane. These are due to enlargement of the cornea. And folds and Descemet's membrane in right lower picture, you can see the folds and Descemet's membrane. They are the signs of ocular hypotony and post-surgical, as the post-cataract extraction, you can find the folds in Descemet's membrane. Now come to some special investigations of the cornea. Pachymetry is a procedure in which we measure the thickness of the cornea. We have mentioned previously that the thickness is relative to certain diseases like keratoconus, primary open-angle glaucoma, and in refractive surgery, we decide according to the thickness of the cornea. The specular microscopy, by this specular reflection, and we see through the microscopes, and we can count the endothelial cell count. And this endothelial cell count is very, very important when we intervene into the eye, particularly the cataract surgery. If already the endothelium is compromised and cell count is low, below 1000 or 800 millimeter, 800 cells per millimeter square, this surgical intervention will further decrease the cells count, so all the possibilities of bullous keratopathy after cataract surgery, particularly the pseudophakia, so this causes the bullous keratopathy. You must be very, very careful doing the surgery in patients who have less number of cells. And keratometry is a procedure where we measure the corneal power. And corneal topography, where we measure the all parts, it's the corneal keratoscopy or the topography, where we can measure very, very accurately the each corneal power of each portion of the cornea. And it is very, very important in the refractive surgery, and we do the orb scan or corneal topography before refractive surgery. So the microbial investigations to see which type of bacteria or microbials are present in this corneal disease or having the corneal ulcers, we take the corneal scrapings and do corneal staining, particularly the gram staining. This gram staining differentiates the bacteria into gram positive and gram negative bacteria. And then we do the culture and this inoculate this scrapings onto certain culture media. Blood agar, blood agar media is mostly for almost all the bacteria except Neisseria, Haemophilus, and Moraxella species. And this chocolate agar is from for gram-negative bacteria, particularly the Neisseria, Haemophilus, and the Moraxella species. And Severod agar is for fungi, and brain hard infusion broth is for fungi, and non-nutrient agar seeded with dead E. coli is for acanthamoeba. Acanthamoeba is a protozoal infections. And buffered charcoal yeast agar is also for acanthamoeba. And still, if you have doubt in the diagnosis, you can take the corneal biopsy, and corneal biopsy is helpful in certain corneal diseases. Now we will briefly discuss the principles of management of corneal diseases in general. In later lectures, we will discuss the management of each disease, but here we will discuss the only principles of management of corneal diseases. What is the aim of treatment? The aim of treatment is to control the infection and inflammation and to promote the re-epithelialization. To control the infection and inflammation, we use antimicrobial agents, antibiotics in drop forms, topical antibiotics in normal concentration, usually 0.3% are available, but we can use the fortified antibiotics according to the severity of the infections. And topical steroids and systemic immunosuppressive agents are used to curb the inflammation. But as far as undergraduate level or at the level of general duty doctor is concerned, they should not use the topical steroids as they cannot judge the judicious use of steroids very accurately. You leave these use of topical steroids to the eye specialist. And as far as promotion of re-epithelialization is concerned, it is very, very important. If cornea is re-epithelialized, then the remaining disease or cornea repair itself very early. Otherwise, this ulcer lingers on. This you can do with the help of lubrication. We use many in tear forms, in gel forms, and certain drugs which promotes the epithelialization. If it fails, we can close the lids, as due to the constant rubbing of the lids, epithelium cannot regenerate. That means we can do the topography. We can use the bandage soft contact lenses for that purpose. If they are not working, we can use the amniotic membrane grafts. We put the amniotic membrane grafts over the disease portion or ulcer so that underneath the epithelialization occur or the epithelial grow over the substantia propria. And the other measures which we can use to heal the corneal ulcers are the tissue adhesives. Cyanoacrylate glue can be used to seal the perforating ulcers or perforating portions. We can use the conjunctival hood flaps. We place the conjunctiva over the cornea so that the corneal epithelium and ulcer heal underneath the conjunctival flap, and after healing we can remove this hood flaps. Limbal stem cell transplantation may be used. Auto stem cell transplantation from same eye or from other eye can be used. If all these measures fail, then we can use the keratoplasty. And keratoplasty is of mainly of two types: lamellar keratoplasty, superficial lamellar and deep lamellar, and total penetrating keratoplasty, where whole of the cornea is replaced. In case of lamellar keratoplasty, only the substantia propria is replaced, but endothelium and Descemet's membrane remain of the recipient. So that is the all about basics of the cornea and evaluation of the corneal diseases. Ladies and gentlemen, I am thankful to you for patient listening. Now I am giving you the assignment. So you must mention the classification of keratitis, how will you investigate keratitis, and what are the general principles of management of keratitis. And please send your assignment to under mentioned WhatsApp numbers and email address. I am thankful to you, ladies and gentlemen, dear students, for patient listening. Thank you very much.